My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. I'm pleased to be with you today to help moderate the session and to provide a little housekeeping right off the top for the town hall. We will have our Q&A function open today, so you'll be able to post questions in the Q&A function. Please keep the chat function for our celebrations at the end of the town hall, which is our custom, and think throughout the course of the presentations about both questions you might have and celebrations you might want to give. When you do put a question into the Q&A function, our presenters will answer it, and you'll see those answers line up in the Answer tab. So you can review them there as our presenters are able to answer. And if you don't get an answer in the town hall, perhaps someone else needs to answer the question you asked, we'll make sure that it gets to the right subject matter expert and email an answer to you. And of course, you can always email questions out of sync with these town halls to the HHS News at hhsc.ca inbox, and we'll have that information up later in the town hall, so you are able to do that. Okay, well, I think that's just about enough from me. To kick things off, I'll invite our President and CEO, Rob McIsaac, to tell us what we can expect to hear about today. So Rob, over to you.
Thanks very much, Aaron, and good morning, everyone. And thank you all for taking some time out to join the town hall. I'm hoping everybody's had at least some opportunity this summer to disconnect, to get some vacation, and hopefully to recharge a little bit. As is our tradition, as we begin, I want to acknowledge that we're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. Unfortunately, this summer is not what we had hoped for in terms of the state of our hospital. Another wave of COVID combined with ongoing staffing pressures and very high patient volumes, as you'll hear from Sharon following this presentation, has added very significant pressure to our system. I know that teams across HHS are struggling to keep up despite their very best efforts. And as a leadership team, I want you to know we're doing all that we can to try to find and create opportunities for relief from this very challenging, very difficult situation. Unfortunately, there are no easy solutions, and I expect it will be quite some time before we can find the stability in our workplace I think that every one of us is craving. Finding a new normal that is sustainable is going to mean finding new ways of doing things. We just will not be able to go back to the way things were, at least not for the foreseeable future, given all of the challenges that are facing us. For now, we're doing everything we can think of to try to address the situation. We remain in touch with our health and healthcare providers and municipal partners across our community and across our region to try to mitigate pressures on HHS. We've assembled working groups to tackle big issues like ED capacity and backlogged surgeries and health human resource challenges. Notwithstanding that, I know that many of you continue to work long hours under trying circumstances, and this update probably doesn't bring any solace, but I mean, I wish I had better news to share. The stubborn fact is that our community and our region need the care that we're providing. Patients keep showing up, and we can't turn them away because in many cases, there just is no one else but us to provide the care that they need. I think right now, the best we can all do is to keep moving forward with compassion and kindness and creativity. Our community is relying on us, they need us. So compassion for our patients and colleagues continues to be so vital. Kindness towards those who may be struggling, and creativity from all of us to try to overcome the barriers that we're facing. Thank you all for the work you're doing to keep us going. I'm really proud of the team here at HHS, and it's quite stunning what you've accomplished and delivered under the most trying circumstances. So thank you again for what you're doing. I'm going to ask Sharon to maybe add some detail and some color to my comments in terms of what the challenges are facing operations. So Sharon, over to you.
Hi there. Sorry, everyone. Just a little glitch here with my audio and my visual. Hello, everyone. Nice to see everyone today. And thank you, Rob, for those comments. In terms of an operational update, I'll start as I usually do in terms of our COVID numbers. So we've not seen that decline that we might have hoped for, but we certainly weren't anticipating. So sitting at 88, less than 5 patients in the ICU, and we currently have 3 outbreaks, 2 of those at the Juravinski and 1 of those at St. Peter's. And we continue to sit around 185 to 200 staff in self-isolation. Those occupancy numbers are unwavering in terms of where we sit close to 100 and certainly above 100 at our acute sites. I'll just point out McMaster sitting at 73%. There's a lot of fluidity in our activity across the site, particularly at McMaster. We know we've seen some unprecedented ED volumes at that site in recent weeks, so it has stabilized a little bit, but there are inordinate bed pressures with McMaster Children's. And you'll note that our ALC numbers have not declined. We continue to sit just slightly above 200, and certainly inordinate pressures at the JH, the General, and the West Lincoln site. If we go to the next slide. Those capacity pressures certainly are not isolated to HHS. We know they're widespread across the region, the province, and certainly across Canada, and lots of media about that. We are seeing those increases in ED closures happening across the sector, again, nationally and certainly locally. We do have a role to play, and we are sitting at the tables with our partners across the region and working on strategies to ensure we support those small centers the best we can for their communities and to ensure there's opportunities for access within those areas, and certainly supporting from a staffing perspective and also from a physician support perspective. We also are working hard provincially with our peers to ensure at HHS we're preserving access to our emergent and our regional services. And what that means is really working daily with our partners to ensure those patients that don't need to be here are transferred in the most timely way back to their home hospital. If we go to the next slide. The bed capacity pressure, certainly what I noted above the 100% occupancy, driven by cross-sector HHR challenges. So I've spoken many times about the challenges within our community partners as related to health human resources. We're also seeing increased impacts as related to caregiver challenges as they're impacted by COVID or their families are, and the stressors within their own homes that make it difficult to be able to provide that caregiver role. As Rob mentioned, we have avoided bed closures. We've had a few closures across the sector. We need very much to be here for our community, and there is nowhere else for patients to go. And certainly when there are other opportunities, we're working within the region and with those community partners to look at alternative opportunities for those patients. For the next slide, please. In terms of our surgical activity, we continue to remain far below our pre-pandemic volume. So remain at 75% of our surgical and procedural activity for HHS. Next slide, please. And in terms of some of the staffing impacts, as I noted on the first slide, we have 183 staff in self-isolation. We haven't seen an increase in our non-COVID illnesses as well. As we're also seeing, which we know is a trend across multiple sectors, is we're seeing more retirements as some individuals are choosing to leave the sector and retire perhaps earlier. And you can see where we're trending this year, but twice as many as we saw last year with respect to retirements. And the next slide, please. Some of the mitigating strategies Rob talked about, lots of planning within our local and our regional IMS structures. We have regional tables set up to look at some of those key system issues like the ED pressures that we are experiencing, like the issues with repatriations and hospital transfers. We continue to advance our admit avoid strategies as we can with partners like SE Health and Home and Community Care. We are continuing to advance planning for the additional beds at the Satellite Health Facility. So we hope in the first 2 weeks of September, we'll have a portion of those 30 beds open, which will help with flow from our acute sites. And certainly that regular public messaging about there are alternatives to the hospital when you do not need hospital level care, whether that's primary care or urgent care center or other community-based services. Also reminding the public about our wait times. And you'll see in over the course of the next week, we'll be posting some signage about respecting our healthcare teams when community is in hospital, given things are slower because of the pressures we are experiencing. And I think maybe one more slide. In terms of some of the other mitigating strategies, we have introduced standby teams to address the staffing situations that we have. We've introduced the agency staff, certainly expanding our internationally trained nursing program, ongoing intensive and aggressive recruitment efforts. And we have been pleased with the centralized model that we have introduced that has helped us reduce that onboarding time, because we have to be as efficient as we can. And I believe that's my last slide, and I will hand it over to Dominic.
Yeah, thanks, Sharon. A very brief update on the epidemiology. I haven't spoken here for quite a while, so quickly recapping, what you see here is hospital admissions in Hamilton, so just our city centrals and HHS. Please disregard that orange peak, which are suspected cases. This was a coding issue with the transition to EPIC, where we overcalled suspected cases. Focus on the red bars, which are the number of people with COVID-19 in our hospitals in the city. And you can see there's a small increase this week compared to last week. And when I'll show you the further data, we sort of expect that we are plateauing at this point. Next slide. Just for context, I added here which waves we are talking about. The most significant one, as you can probably still remember from earlier this year, was the first Omicron wave. And the third Omicron wave now over the summer behaves quite similarly when we're looking at hospital admissions as the second. It looks like slightly less hospital admissions than back then. Keep that in mind. I will show you the ICU data shortly. And on the next slide, you will see our current trajectory in Hamilton. That's from the public health side website, which looks at multiple metrics, and pretty much everything is stable other than outbreaks, which are trending down at this point. So it really looks like you might be at that, and as you will see later, first peak of this so-called seventh wave. Next slide. At the provincial level, it looks like we are already past peak in terms of hospital admissions. Again, similar picture as with the second Omicron wave, slightly lower hospitalizations than back then, but the peak was 2 weeks ago. So it looks like we are lacking maybe 1 or 2 weeks behind the provincial trend. Next slide. As I mentioned, when we are looking at the ICU, the picture becomes very different, and I put the third Omicron wave in air marks here, because when you just look at ICU data, you wouldn't see a peak at all. And if the data from Hamilton Public Health is correct, we haven't had a Hamiltonian admitted to the ICU with COVID for months now, despite the fact that we are going clearly through a third wave of Omicron in the community. And this certainly is the benefit, or that's the effect, I would say, that we started to see when we were rolling out the vaccines, where we started to see more and more of a disconnect between case numbers, number of hospital admissions, and in particular ICU admissions. And now combined with some level of natural immunity from the last 2 Omicron waves, the impact on the ICU at this point is very minimal, if at all, despite the fact of significant spread out there, as you could see based on the isolation data in our staff. And also to add to that, the vaccines remain to be safe, right? I mean, that there's people who said, like, after 1 year, you will see side effect X, Y, and Z. hasn't happened. It hasn't happened the same way as the other people who would have said we are exactly the same boat as we've been 2 years ago or before the vaccines, because they are not perfect. Yes, they are not perfect in preventing infections, but they do an awesome job when it comes to preventing severe disease. Next slide. Looking at the predictions here, and these are the predictions here from Hamilton with the modeling for what we might have to expect going into fall and winter. You can see that where I added the first peak, second week of August, that's where we think we are at this point. And you will see that the number of hospital admissions from currently roughly 2 Hamiltonians per day will drop back to about 1 Hamiltonian per day up to the end of September, beginning of October, and then it's expected to go up again back into a range where we had been in spring with our second Omicron wave, our spring wave. This is barring any new variant of concern, obviously, that may have more of an immune escape, etc. This is assuming that BA4 and in particular BA5 continues to be the predominant strain. So a peak in winter, probably similar in significance from a healthcare perspective as our spring wave, but you see a lot of gray around that blue line, which is sort of the best and the worst case scenario. And as you can see, the best case scenario would be similar to what we are currently seeing, up to a scenario which would look very similar to what we've seen at the beginning of the year. So again, a lot of uncertainty. The most plausible scenario will be similar as what we went through in spring from a hospital perspective. I think that was my last slide, handing back over to Aaron.
Thanks very much, Dominic. Okay, next up on our agenda, we have an update on our EPIC process, or I guess our project Odyssey process, which is winding towards becoming our EPIC system. So Barry, where are we at today?
Thanks, Aaron, and hey, everybody. Good to be with you again. We can go, I think, really to the next slide. This slide is obvious to everybody now. We are live. We are in phase 5, and you know, if I have said it many times, but I'll just say it real quick again. What this organization has accomplished with EPIC is truly spectacular. We are, and you're going to hear a little bit more about these post go live assessments, but you know, the folks from EPIC are being very positive on how Hamilton Health Sciences has performed in an EPIC implementation, and saying that happened in the middle of COVID wave, whatever, and the most severe health human resources crisis in the history of the province is really just an incredible statement. So we are in the go live period, and there's much to be done. And I would like to emphasize that go live is the start of stabilization. Stabilization will then be followed by the processes that will go on for years of optimization. And so although we operated at warp speed in the first few weeks of go live to deal with all the very severe or very concerning issues that needed to be addressed, there's lots of work to be done to improve workflows, continue to deal with ticket volumes, and to find any ongoing areas that have major clinical implications that we need to be sure to deal with before we try to transition into the optimization phase. I would like to also remind you that although the at the elbow support, which we had for 8 weeks in the organization, has now gone away, there's always the opportunity for help through the help desk, through the 43,000 number, or the My IT process directly within Citrix. I'm going to say a few words about a few more words, I guess, about the post-live visits in a moment. And I would just alert you, and you will hear more about this, but we will be doing our first post go live downtime beginning at 12:30 a.m. On August the 20th. This is a critical update to the system that will take a couple of hours. Hopefully will be very smooth, and you'll hear more and more about that as we approach that next Saturday morning in the wee hours. This is an extremely important update for us, but it's also an opportunity for the organization to test itself in the downtime environment. And I think I will move on to the next slide, please. Those of you who attend these town halls regularly are getting pretty familiar with this slide as well as the first one. Really, we just want to point out a couple of really important items that are a good example of how EPIC is working. And one is that we have had now 7,000 virtual care appointments through the EPIC environment, which is spectacular. This is something that, if you're not aware of, can be built right into the clinic schedule. The patient can receive the link for their video assessment directly, either through MyChart or otherwise, and the clinician can then do that visit directly in system. So that's really a fantastic opportunity to enhance virtual care, which of course is almost certainly going to continue at the same kind of pace going forward. Lots and lots of other really cool stuff, including well over 140,000 secure chat messages, and now approaching 17,000 MyChart registrations. Next slide, please. Here's just a little bit more about the post-live visit. So EPIC has a very structured process, no surprise to anybody. And this includes a whole series of what they call post-live visits and surveys. So a couple of weeks ago, a survey went out across the organization. It's short, but it gives people an opportunity to provide their feedback. That will close today at 5 o'clock, and I would encourage you, if you haven't taken a moment, to please take the opportunity to complete the survey. That survey will be compiled and then compared against our peer organizations to give us some feedback of where we're at and how we've done. So it's a very important part of their process. And the second is what's called the post-live visits, where teams from the Odyssey group are going out to the units and hearing the feedback directly, not from the Odyssey folks, not from the directors and the managers so much as actually people at the front line, and to help us hear how it's going, what we can do better, and obviously we're keen to hear what's going well. So this is the first visit. The next one will be in October, and then there will be another one in the fall, and we'll receive a formal report, both with regard to the survey and to the post-live visit, which obviously the team will take and you will hear more about, and we'll be sure to provide some information about that. Next visit, or next slide rather, sorry. For physicians, we are working very hard to be sure that we continue to enhance the training opportunities for our physicians to allow them to be as effective and in the EPIC environment. And so there's a whole series of processes that we're putting in place to allow physicians to what we're call have mastery or to thrive in system. You'll hear some more about that if you're one of our providers, but it's a really, really important opportunity for physicians who may have survived training, are now able to function in system, but the opportunity to actually thrive in the system, spend less time, be more efficient, and to have a greater level of satisfaction. Next slide, please. So this will include a series of 4 different 90-minute virtual sessions that will be conducted by our HHS trainers to provide more opportunity to thrive in the Beacon environment, in basket for everybody, phases of care for virtually all of our practitioners, and then to be very much more adept at the process of orders and notes. There's also a series of 180 what they call It's Possible videos that are available in system for any docs who are or providers who are on today, if you just click on the little Earth icon in the top right of the Epic system, it will take you into an area where you can identify videos that might be of help, and you can take the opportunity to review them. They're all short and sweet and very easy to follow. And then there will be a great opportunity for folks to become power users, and there's a whole curriculum along with believe it's about 30 different opportunities to become a power user. So all of this is really meant to take us to the next step in terms of efficiency and provider satisfaction. Next slide, please. So some reminders, and there's really an important one here, which I want to take a moment to emphasize in terms of registration of patients and the concern or the potential for patients to be misidentified or inappropriately registered in system. And when this happens, of course, it relates very much to the potential for a serious privacy breach, where, for example, a patient might in fact be sent a MyChart, a registration for somebody else, and their information then that they're seeing isn't theirs, it's somebody else's. So it's all about being sure that at every opportunity where patient registration occurs, whether that's inpatient, whether that's ambulatory care, whether that's the opportunity to register people for MyChart, whether it's in the secure chat or the in-basket environment, and of course in the day-to-day charting, that the patient is the right patient. And in order to do that, the standard is, of course, that we need 2 identifiers to ensure that we have the right patient. We need to be very careful whenever there appears to be the opportunity for a very common name or duplicate names or very similar names. And so whenever possible, this needs to be watched very carefully. The OHIP number should be the first source of truth, or the medical record number, and then some other second level of identification, such as date of birth. And it's extremely important that we never override the demographic information like the date of birth and the OHIP number in system. Any questions, please always call 43,000 and we'll be happy to help with this. And we will be socializing this across the organization, both in the hub and the provider daily critical reads. If you are having problems related to patient flow, the opportunity for rapid escalation still is in place. And just one last emphasis is that secure chat is a fantastic communication tool for day-to-day care, but it should never be the tool for urgent care. Anything that requires urgent or emergent action should always be done using that old-fashioned device called a telephone, and never please depend on secure chat for that kind of patient information or decision making. And that would be me done, I believe.
All right, thanks very much, Dr. Lum, for that update today. Okay, we have had the opportunity, our Q&A function's open. No one has availed themselves of that opportunity throughout the course of today's town hall, but a reminder to everyone that if something comes to your mind that you'd like to ask, and maybe you didn't, you can always send an email to hhsnews@hhsc.ca, and we'll make sure that you get an answer promptly. So that's the way to do that. All right, moving right along. I believe now we'll head to our celebrations. So this is an opportunity for our participants as well as our panelists to give a shout out to someone, something, some team, something you've seen, something you'd like to remark upon that's extraordinary in the organization. Rob, I see you have come on camera and unmuted. What would you like to celebrate today?
Yeah, I just wanted to give a shout out to Michelle LaRue. It's her last week here at Hamilton Health Sciences. She's moving on to some new challenges. So thanks to Michelle for all of her contributions here at Hamilton Health Sciences, and very best wishes for every success going forward.
For sure. Thanks for that. And any of our other, I don't see any participant hands up. As a reminder that you can put your hand up and you can give your shout out loud, or you can type it in the chat forum and we'll read it out on your behalf. Okay. It's not a celebratory day today. All right, well, we'll leave it at that then with our profound thanks to everyone for making time to be here. Rob, final words to you. We'll see everybody next time.
Yeah, thank you, Aaron, and good job as always. And thanks everybody for joining in today. If I start off by saying I hope everybody's had a chance to get some vacation. There's still some summer left, so hopefully, if you haven't had vacation, you'll take advantage of the balance of the summer to try to get some R&R in and to recharge. Once again, my thanks to everybody for all that you're doing. It's very much appreciated. I hope you have a great rest of the day and a great rest of the week. Cheers, everybody.